Hello, guys. This is Dr. Palaniappan Manickam. I'm so glad to have a special guest in our channel today. He is the president of Obesity Surgery Association of India. He is an international federation of excellence. அப்பா சொன்னா கோச்சுக்குவாங்க. On the top of it, he is a director of the GEM hospitals, the famous hospitals in Coimbatore. And more than that, he is my best friend, close friend. I've been with him forever. And he's one of the main reason that I'm here in this situation. Okay, so let's welcome Dr. Praveen Raj. He is the obesity surgeon in India.
Hello, Dr. Pal, and hello, friends.
Hi, Dr. Praveen.
Nalla irukken.
Super nice.
Finally, after a long time.
After a while. So, just for our channel audience, is that, we both studied medicine together in PhD, IMSR Coimbatore. And, we have chatted a lot of time together. The problem is we chat during the class so that the professor will actually catch us right away. And on the top of it, he has been like my mentor, advisor, and most often than not, we have bunked classes together as well. And then if I tell him, he's going to tease me for that. But anyways, the main reason for bringing him on the channel is that, we have been talking about belly fat in our channel, and he is the obesity surgeon. I mean, laparoscopic bariatric surgeon back home in Coimbatore, India. And I thought it'll be a fantastic discussion to bring him on board and then talk about what is the exact obesity prevalence, what does he do, and just to reassure you guys that what I am saying is right as well. Okay, so first, Praveen, let me start with this. So how many patients with morbid obesity that you see in a daily basis in your clinic, just to see what is the prevalence of obesity in India now?
Okay, Pal. I think the great topic at the right times, because I think people have actually started realizing the importance of obesity after COVID actually came, and there was mortality when it was starting to be higher with the obese people. So that's when people actually started looking at obesity as a disease. So with regard to the prevalence, and I think it's because in GEM, being a gastro center, we see obese people, people coming for obesity treatment by itself, and keep people coming for other diseases also, who do not come for weight reduction, but however come for other problems. I think over the years, when it was believed that obesity was a disease of the affluent countries or the developed countries, and I think now the developing or even many underdeveloped countries are catching up in obesity in a very big way, and the numbers in India is getting huge. I mean, not just post-COVID, sedentary lifestyle at home, but even prior to COVID, the numbers were high. Just to give you an understanding, I did a study in schools. It was called a Childhood Obesity Prevention in Schools program, where I noted about 16% obesity in kids in India. This was a study in Coimbatore. And with adults, if you really ask me, 1 in 4 are easily above the BMIs of 30. So roughly about 25% of incidence is what we see. Again, people coming for weight loss and non-weight loss and putting everything together,
right? So I think the 1 in 4 here in United States, what I've been seeing the last 5-6 years is it's a drastic difference between southern states and northern states, or as you know, with the United States, everything is like two times, right? Either it is right, left, obese, thin. Either they are like so health conscious that they are like so lean. If not, they are like morbidly obese. And in my practice, at least 1 in 2 patients come with any problem, with any GI problems. So it has been an ongoing issue as well. So let me ask you this. So I have been in my channel, I've been talking about, please reduce the belly fat, and I don't think people are listening to me anymore. So why don't you reassure or tell them that what is the risk of having belly fat?
Okay, I think I've seen Pal's videos. I think they've been really wonderful and interesting. But I think to make it simple,
for the namesake, I don't think he means it.
Actually, yes. For the namesake, I haven't seen the videos actually. Yeah. So coming on to the point about reduction of belly fat, generally we believe disease is a disease when it is going to cause some trouble. So for us, diabetes is the disease. Cardiac issue is a disease. Ulcer is a disease. But we don't look at obesity as a disease. Obesity people think it is a sign of prosperity even. But then obesity is a disease. And no more than COVID. I mean, after COVID, we realized the amount of the death percentage, big number one morbidity to actually cause COVID mortality was obesity. Because obesity is a disease by itself. In fact, it is a precursor of most of the diseases that we think as disease, which is diabetes, hypertension, dyslipidemia, menses issues, PCOD, sleep apnea that you have, knee pains, back pains. Certain cancers are also predisposed by obesity, like colon cancers and prostate cancers and breast cancers. So treating obesity is not to look good, but to actually live. So you don't think you're having 250 sugars and say, my sugar, I mean, it is okay, I'm feeling healthy. You would go to your doctor and treat, because you know tomorrow there could be ulcers in your legs, your leg could be taken off. Same with obesity. You can just become nobody in any day. In fact, most of the people who snore in the trains that you see are actually suffering from breathing difficulties. There's a high potential that they could die in their sleep. In fact, most obese people, if they die in their sleep, we think he had a heart attack when he was sleeping. No, he actually died of a sleep apnea, which is because of obesity. So the disease by itself, so to losing is to live.
So here, right, in what I see here is like the patients are like apple obesity type, right? They're like big and it's very obvious that they're obese. But I have been like reassuring or re-emphasizing the point that for Indian ethnicity, I think the problem is the fat is getting deposited in the belly. Don't you agree?
Absolutely. See, I would actually compare the West and the Indians. If you actually see the US guys, they'll be like fat from top to bottom. It's like a general obesity. Although central obesity is now catching up in a big way, even in the United States, the fat is more generalized. So being obese means it's just not fat. There is a lot of fat outside, and they're also muscular because they eat a lot of meats. But in India, I wouldn't say just India, but in the Asian side, the obesity is more central. If you see in the women, it is more in the waist. You see in the men, it is more in the abdomen. If you actually look at their legs, it'll be like thin. Kuchi marda irukum kaal. Ukkandirukku vatha ulliya irukka mari irupanga. When they get up, you see that big punch coming forward. Right. This central obesity is much more dangerous than generalized obesity. Take it from me. Anybody you see that's having a huge abdominal fat, just go and ask them, are they having diabetes or hypertension? 9 out of 10, they will have one of each. Because the central obesity is directly linked to metabolic disease, which is diabetes, hypertension, or cholesterol. So that is the dangerous aspect of it.
And central adiposity is the belly fat that we're talking about.
Yes, central adipose. So basically, the fat is inside the abdomen. It's not outside. When you actually touch their abdomen, you will see the abdomen is very tight. The fat is internal. It is internal around the intestines, in the liver, in the mesentery. So this internal fat gets swollen. That increases the abdominal pressure, that pushes the abdomen outside. So if you actually touch the abdomen, you feel like it'll be like tight. So this is the dangerous aspect of it.
You remember, like when I was obese, I used to have this big chicken biryani in Kanishka restaurant in Coimbatore.
I know. Wherever there was unlimited meals, you'll be the first person to say, unlimited meals. I know there was so much of craze for these unlimited meals.
So
and I think you were the ones leading it. So yeah.
So I think even without our knowledge, it has been like slowly creeping in. So let's say that a patient realizes that, okay, he is obese, he has tried so many things and he's not losing weight. And so that patient walks up to your clinic. And then what do you usually tell them in the first place? How do you manage?
Okay, I think first of all, I mean, guys who are watching this video, what you need to understand is whenever you look at somebody obese in a cinema theater or in a mall or in a wedding, first, the normal mindset would be, nalla சாப்பிடுவான் போல, நல்ல மூக்கு புடிப்பு சாப்பிடுவான் போல. That is what we tend to think. And also, we also think, அக்கறையே இல்லாம எப்படி இருக்கிறான் பாரு. This is the first thought that comes to our mind. Because we always have been told to think somebody is obese means he eats a lot. First of all, that is a misnomer. Let's break the myth. Maybe we'll talk about it in the next couple of minutes. But when I see a patient with obese, as I told you, it's a misnomer. So many obese patients may not be eating more. It could be many times that you could see in your experience. There are some people who eat a lot, who don't do any exercise, but who will be like thin. There are people who eat right, do their best possible, but will be obese as such. So first of all, when I see a patient who's obesity, we need to differentiate, is it hyperphagic obesity or metabolic obesity? Hyperphagic obesity means, is he eating and actually is that responsible for his weight, or no, is he eating all right? Is there a poor metabolism that's causing the obesity? Because the treatment will differ. Same BMI, same age, but if it is hyperphagic, the treatment will be different. But if it is metabolic, the treatment will be different. So this is the first thing we try to understand before we even further get into the treatment of it.
But how do you differentiate it based on their eating habits? You just ask them?
Yes. So basically, we have certain questionnaires where we tend to look at, or the simplest thing will be what is a food recall. We tend to sit down because basically before I see the patient, my dietitian, my bariatric coordinator sits with the patient. This helps them understand where are the weakness areas are there. So this could be starting from their eating patterns. Are they hyperphagic or many times polyphagic? Hyperphagic means volume eating. Polyphagic means frequent intake of high caloric foods, or whether you're normal eating. So this is number one, that's important. Or many times they could have psychological, this is by night eating. The sleep, they'll be eating chocolates. In the night, they'll be eating a lot of snacking. They may not eat during the day, but in the night, because they could be working in call centers, they could be stressful work, night eating could be there. Then we need to understand the psychological aspects of it. Are really stressed? Are they depressed? Are they going through any personal issue? Because stress makes them eat more. So stress management is going to be very important. Then are they having any physical abnormalities like joint pains or back pains? Is it restricting their work, etc.? Because you cannot tell somebody with osteoarthritis to go for a walking, to go and start doing exercises. Then comes this understanding of the diseases like diabetes, hypertension, etc. So with this story in the mind, now we will tend to understand what is his actual pain. BMI, so the number doesn't tell what is their problem is. Absolutely. You cannot just see a BMI of 40 and say this is going to be a treatment. Right. With this understanding, then we start tailing the treatment. If let's say they're drinking every day, they're eating well, that is a problem. You just need to counsel them, sit down with them and make them understand you need to start reworking on your diet. So the diet aspects have to be corrected first before even we start looking at anything. But on the other end, patient is eating a moderate eater, not really high caloric eater, doing their best possible. They have joint issues. There is a metabolic issue. They have diabetes, hypertension. Then we need to start getting them medical. You cannot keep again telling them do diet, go for, because these obese people get hundreds of advice from everywhere. Everybody in a wedding, everybody in a mall comes and gives them advice. Yeah, walking for the layer.
Including Dr. Pal channel.
So அந்த அட்வைஸ் ஈஸியா கொடுத்துட்டு போயிரும். அவங்களுக்கு தான் தெரியும் என்ன பிரச்சனை.
That's absolutely.
Exactly. So see, basically that is what we need to understand before we even recommend a treatment. You cannot just blindly go back and say கம்மியா சாப்பிடு, பாதியா சாப்பிடு, சப்பாத்தி மாத்திக்கோ, walking போ. The free advice please do not give. There are doctors to actually help them. So this is something we need to look at it. நான் பழனியை சொல்ல I'm just saying
ஏண்டா கேட்டாங்களா அப்படியே. Okay, so if a patient, okay, you have decided that his eating pattern is the reason for his obesity, right? And usually by the time he comes to you, he will be like, I tried this keto diet, I tried this paleo diet, I tried time restricted feeding, something like that, right? Do you do surgery on them right away, or you give them an option to try again under supervision? And why not do surgery? If not, why not do surgery right away?
Okay. See, first of all, if they are, surgery is for somebody who wants to lose weight and is unable to lose weight. It is not it's not a shortcut. It's not something for, it's not like that. So let's make that very, very clear. So now somebody who's tried everything, but who's fed up, who's not able to go through the same thing, maybe he's not getting the right results, maybe he's having medical issues, then he's reaching out for a surgery. Yes, we can start considering a surgery. But he's like, doctor, nammala mudiyadanga, namma business na traveling la irpen, party apdi ipdinga. So if he's not really motivated, then even if he's having medical issues, even if he's suffering, probably we shouldn't put him under the knife, because he's not somebody. See, first of all, they need to win a surgery. The sense they need, it is like they need to be so motivated that they need to win a surgery. If they look at it as a shortcut, because tomorrow he'll also struggle, I will also struggle, we don't offer them surgery. So it is for somebody who wants to lose and who's trying, but who's unable to do for practical or whatever reasons.
Right. I see these patients with, weight of like 150 kilos, 175 kilos. And then I said, okay, why don't you try for gastric bypass? And they were like, I already had, doctor. I was like, how come you had this gastric bypass surgery and then you still have like 150 kilos, right? Because the behavior, the mindset, the lifestyle has not changed. So no matter what surgery he has, he's going back to the same lifestyle and then just get, fat again, unfortunately. So
not a great example, as you say, you have a wrong patient, you have a wrong result. So that is why I said laziness kaga nama pannona, that is what will happen. You might see 150 kilos, they can come back because it was the wrong patient who was operated.
Absolutely. So nowadays people are actually choosing obesity surgery as an LS cesarean section date. sometimes they say, oh, I want Friday morning 8 o'clock. ஏன்னா அதான் நல்ல நேரம். அந்த மாதிரி எனக்கு Thursday evening 5 PM obesity surgery பண்ணீங்க, நான் நாளைக்கு ரித்திக் ரோஷன் மாதிரி ஆப்பறேன்.
So அதனால see, people have unrealistic expectations sometimes. I think it is, in fact, as a doctor, I always in a patient பார்த்து முடிச்சோன்னு சொல்லுங்க பாரு, உங்களுக்கு சர்ஜரி பண்ணுமா வேண்டாமான்னு சொல்றது is not my responsibility. My duty is to educate you, make you understand what it is. Now you choose what is it right for you, come and get it done. In fact, doctors, we shouldn't be choosing it for them. We should be advising them, educate them, let them go sit down with their family, take a call and come back. In fact, so now what has happened is, after so many years of practice, 90% of our patients who actually come properly educated, who knows that they are the candidate. In fact, I saw about, since morning, I've seen about 3-4 patients. Everybody had come pre-motivated for the surgery only. Patients just walking in, telling a surgery, going and thinking about it, has actually gone down because literature is there everywhere. Now they exactly know when to come and when not to come. Our duty has only become like not doing it on a bad patient. If I see a bad patient, I tell them, you change this and come back after 3 months, let's take a call. So that is how things have changed.
So you have a protocol, to follow before committing to the surgery.
Very true. See, again, if you choose a wrong patient, the sufferer is not going to be only him, it's also you. Because you will have, because post-surgery, see, surgery is not like an end. It is a starting point of a new phase. So this requires a committed lifestyle from the patient, support by the family, and a multidisciplinary team from our end who will work along with the patient. So if you have a bad patient, the whole family will struggle. Our team will also struggle. At the end of the day, why we lose weight? To improve the quality of life. Let's say, for example, he's not able to follow, but at the same time, we are forcing him. Weight loss might be happening, but he may not be a happy guy. For that, let him eat happily and die happily. We can just leave it off instead of bringing it in, and all of us struggle. So choosing the right patient is something very, very important in our practice. In fact, many of the training programs, this is what I teach our fellow colleagues also. Just because the patient is coming and asking for surgery, please do not do. You will have a nightmare.
So tell me, you have been talking about the right patient. In your mind, what is the right patient?
Right patient is one who realizes that he needs to lose weight.
Okay.
And is doing his best possible. See, the best is completely subjective. The best possible to his capacities. I mean, you cannot expect him to be 100%, but at least 75-80% who wants to lose and is understanding weight loss is just not to look good, but to live a longer and a healthier life. This is the right patient for you. Because he's having the pain. He wants to get out of this pain. Now you need to help him. Now you constantly keep telling him, do this. He might actually get into depression because you're trying your best. It's just not happening. You need to handhold him here. When that breaking point is there, because many times what happens is the family members keep them pushing, and nothing really happens. Diet, they would have tried walking, they would have tried paleo, keto. I mean, whatever thing that they've tried, nothing really happens. And one point they get fed up. They throw everything. They become depressed and they start eating too much. Then they stop taking advices. They stop realizing it's happening and they start fighting with everybody. If you go into this phase, then that's even more dangerous. It's so that is why I say, do not give free advice. You do not know which stage they are in. So if they are already in that phase, that pushes them into depression, because it is not that they do not want, but they could not.
Right. So surgery is not a bad thing. Sometimes people think that, surgery, obesity surgery, I'll be able to reduce it. But sometimes, no matter what we do, sometimes we just cannot reduce it. So the other patient population is when they have medical problems, right? Like, you said, talked about snoring. What are the other medical problems that people can think about obesity surgery?
Okay, so I think one of the there are 2 or 3 conditions that's very important, more than obesity, that we consider when we offer a bariatric surgery is one, uncontrolled diabetes. I think in the Indian subcontinent, India is coming there, although not great thing to be the world leader in diabetes. See, having diabetes is not a wrong thing, but having an uncontrolled diabetes is a bad thing, because many patients think having a diabetes, I'm taking my medications regularly. And sugar control question, my question was whether it's under control, because they're really not following whether the sugars are uncontrolled. So uncontrolled diabetes is one indication for bariatric, because post-bariatric diabetes can be even reversed back to normal. The second aspect that we commonly see today for bariatric is PCOD, or menstrual irregularities in the young girls, or they're married, having an infertility that is related to PCOD or obesity. That second very common condition that we're seeing in the recent times, that patients are actually coming for bariatric. So post-bariatric, their infertility actually goes down. Most of them can get pregnant normally. The third important, a life-threatening condition why we operate is obstructive sleep apnea. They have severe snoring at night. Their oxygen levels go down. Carbon dioxide starts going up. They have a poor sleep. Then they wake up in the morning. They have daytime sleepiness. Many of them who's driving can get into accidents. The quality of sleep is gone. The quality of life itself is gone. So getting them treated from obstructive sleep apnea is a third important condition that we offer bariatric. And lastly, with regard to joint issues like lower back pain or knee issues, they go to the orthopedician. Orthopedician changes the knee, but the obesity is not changed, and the knee pain tends to continue for long. So that's another reason.
You see, that's a problem, right? No, you have arthritis, you go to the orthopedic surgeon. The best treatment is to go back to you to get the bariatric surgery done rather than knee replacement, because if not, the new knee is going to have the same problem again.
Absolutely.
Good. Okay, so now, so let's say that, okay, you have identified the right candidate. So what kind of surgeries that you offer and you do, and then can you just briefly say what it is exactly in layman terms? I mean, in my...
Well, you are now the expert for everything starting from COVID to நிறைய விஷயத்துக்கு expert அது எனக்கு தெரியும், but at least with regard to medicine censor பண்ணிடலாம். So basically, even நான் சொல்லிட்டு இருந்த மாதிரி bariatric surgery is a treatment aimed at weight reduction and its related comorbidities. Again, the comorbidities I just mentioned. So the surgeries are done primarily in the stomach and the intestines, or both. There are many types depending on the patient's clinical condition. We choose the right thing to the right patient. The intent is to modify the intestinal hormonal profile so that their metabolism, or Tamil erippu tanmai, because most of the obesity is not linked to just hypereating, hyperphagic eating, but because of a poor metabolic capacity. So because of these hormonal changes that we cause in the intestines, the metabolic rate or the metabolism tends to get improved. And it is because of this improved metabolism, all diseases connected to metabolism tends to improve. The obesity, diabetes, hypertension, and cholesterol I mentioned. And more importantly, after surgery, you may not be able to eat beyond a point every time. Your capacity will be restricted. See, the aim is not to make you eat less, but not to make you eat more at any point of time. On an overall scale throughout the day, you will eat 80 to 90% of the fast. But then you cannot overeat even if you want to eat. So that otherwise the whole thing tends to get broken. So this is the primary phenomenon of bariatric surgery. So that is why, as I repeatedly said, this is primarily for somebody who's trying everything and not able to lose weight. We improve the metabolism by changing the hormonal profile in the intestines.
எப்பா வந்து பிசியாலஜில வந்து ஆன்சர் சொல்ற மாதிரி சொல்லிட்டு
ரொம்ப நாள் ஆச்சு மாதிரி வைவா क्वेश्चन கேட்டு.
So let me ask you this. So, we read about gastric bypass surgery, we read about sleeve gastrectomy, all these are different kinds of surgeries. But in simple terms, so either ways, you are going to cut down the size of the stomach, either by approximating on itself or just connecting to a different angle. Is that right?
Absolutely. So that is the way it is done. But physiologically, there are different mechanisms. But in simple terms, yes, we cut a portion of the stomach, or we cut a small pouch and then bypass it to the intestines. In that, there are certain other varieties, depending on whether they are more obese, less diabetic, or less diabetic, more diabetic, less obese, or the combination of both. We tailor it. There are different combinations of this that can be done.
So I have seen so many patients, because people follow up with gastroenterology after the gastric bypass surgery, right? So I can tell you that so many patients who had heartburn problems, abdominal bloating problems, even diabetes, as you said, gastroparesis when the stomach is not contracting properly, all those disappear in most of the patients that I can actually vouch for it. So I would say like 90% of the time, actually people do get, like a night and day difference after the surgery sometimes, isn't it?
Very true.
Can you share a patient experience that you cannot forget, where they have a life-changing experience after the bariatric surgery?
One patient. So bariatric, honestly, the main reason I took up bariatric surgery itself was the change of life that we were able to give literally every patient. Because every patient have a story of their own. Every single patient. Because in fact, I used to ask my doctor colleagues, obesity surgery pannipingala. So if they are choosing that and coming, the pain that they're going through is big. Many times, even the family members do not understand the pain. In fact, 50% of the female patients that I see in my clinic break down while we actually have a conversation, and the husband will look at them so surprisingly, because the husband would always be telling her, "Oh, you've been lazy, you've been not doing anything, etc." So everybody has a story, but starting from, for example, one of these patients, I mean, I remember, so it's about 10 years back, who was suffering from PCOD, who's having continuous bleeding every day for the last 2 years. And the hemoglobin is almost about 8, 9, because she was having PCOD, continuous bleeding every day. See, I have seen a lot of PCOD patients. They normally don't come with so much of bleeding. They come with lesser bleeding. They come with diabetes, etc. But this was a little different. Every day, imagine a young unmarried girl having a bleeding every day is such a nightmare for her. The only reason she came to bariatric doctor, my gynecologist told me only bariatric surgery is going to help. I was like, I have seen bariatrics work, but I have not seen bariatrics working for people like so much of bleeding stopping completely. I actually did not give her any confidence. See, I'm not sure about so much of bleeding. Let's take a call. Let's try, but I cannot give you confidence. It's a gynecologist telling, so I'll better operate you. 3 months post bariatrics, she came back and said, "Doctor, after 2 years, I'm having normal menses." After 2 years, she wasn't that greatly obese. But imagine that. I mean, we might look at it differently. Imagine a female, she was actually working as a manager in a bank, so which means she was a working woman herself. So I think that is one story just comes to me. Stories with regard to post marriage infertility for many years. I think the one who infertility was 19 years of infertility, went around everywhere. He's a CEO of one of the television channels. Finally, we did a bariatric. 1.5 years later, she conceived normally and finally had a baby. I think so. These are all stories sometimes makes you give so much of confidence, thinking, yeah, you are on the right track. You're doing some good things for your patients. So that is what is driving us on.
No, absolutely. You know, the joy that you see after the surgery, I don't think it's unmatched in any field, right? You know, I can talk a lot about belly fat and everything, but actually you doing the surgery and post-surgical intervention, that is a separate feeling. By the way, to the audience, we always had this debate between me and him during the medical college that I always say medicine is better and he always says surgery is better. And then finally, I'm coming back to him that, you know, bariatric surgery actually works.
Normally the patients, a lot of them have this fear when they come for surgery. I tell them, see, this is like a cesarean section. Yes, you're coming in for the surgery, but when you're going out, there will be a pleasure when you walk out of the hospital. It's something similar to that. Although, yes, you might fear about having a surgery, but the outcomes are going to be enjoyable. Outcomes are going to be pleasurable. So that is what you need to look out for.
Absolutely. So let me just put these things in perspective, right? So we are not saying that, you know, every obese patient should go into bariatric surgery. That is not the idea. So the idea is you try your best. That is the key thing, you know. Even if you go to Praveen and, you know, he's not going to operate on you if you would have not given the best effort that you put in. So what do you tell your patients? I mean, my channel's audience, what do you say if they are trying to lose weight? What is your recommendation in general?
Yeah, the first point is realize you need to lose weight. First of all, understand what is your weight is, because many of them do not know what their weight is only. So check your weight, check your BMI. Motivate yourself that you have to lose your weight. It is not impossible, but it is difficult. Start initiatives. So that maybe, yes, if you can reach out to the right specialist, don't get into the shortcut centers. Go to a right specialist. It could be a fitness trainer, it could be a dietitian, or it could be doctors like us. We would take you through the scientific methods of it. And in the scientific methods of it, yes, depending on your weighing scale, again, we cannot do magic without your support, your motivation. So we need to work together. Yes, at the right times, we would ensure what things need to be done, whether it's a just diet or maybe medical management, or it could be endoscopic therapies, or maybe even a bariatric surgery, because it's a step-ladder pattern. But at the end of the day, the realization to lose weight is most important thing.
You know, absolutely. So I'm so glad that, you know, we had such a good discussion. The key point that I wanted to convey is that you know, we try as much as possible with all the techniques. You know, time restricted feeding that I'm talking about in my channel, just one of the methods. You know, you can try whatever method that you want, but whatever works for you is the best method for weight loss. But let's say in the worst case scenario, you do all these things in maximal measures, you cannot lose weight. You don't have to lead a miserable life. We have like fantastic surgeons like Dr. Praveen Raj all over the world to offer this bariatric surgery. Again, we have to be done for the right patient. And I'm hoping that obesity might not be the next COVID pandemic soon. Huh?
Hopefully.
Hopefully not, right? Yeah. I mean, so let me just close this session by asking you this. You're talking about only this, snoring, PCOS, and diabetes, right? There are like so much untoward complication that we might not even think about. We just briefed about cancer. Since your center is a pancreatic cancer excellence, pancreatic cancer center of excellence, I want you to touch briefly about how obesity causes pancreatic cancer.
Okay. See, with regard to obesity, it's just presence of fat in your body. And this fat can have a chronic low-grade inflammation. And when this chronic low-grade inflammation can actually produce tumorogenic factors, which can potentially lead to development of not just pancreatic. Pancreas means kanayam. It's a type of cancer. Of course, obesity is not the only reason for development of pancreatic cancer, but obesity is one of the important predisposing factors for development of pancreatic cancer. Yes, there are other things like genetic issues, alcoholic issues, many times unknown issues also. So just presence of extra fat in your body itself is not good. Fat is good. See, it is not that fat is a bad thing. Fat in moderate amounts in your body is always right. But when fat goes beyond excess, see, muscles cannot grow beyond an excess. Your bone cannot go beyond an excess. Your water cannot grow beyond it. But fat goes beyond an excess. Then that gets into a phase of inflammation. And this inflammation can predispose to metabolic diseases and cancer. And that is why obesity is one of the predisposing factors, like pancreatic cancer in the abdomen, breast cancers for women, prostate cancer in men, and colon cancers in both men and women. Obesity has definitely a link to play. Again, it doesn't mean that you lose weight. I mean, in a thin patient, these cancers are not going to come. It's not so. Yes, it can still come, but this is one of the important predisposing factors. So that is why, as I again said, obesity is just not about looking good. It's about to live longer.
Live longer. And whatever life that we have to make sure the quality of life is good. As well, I might die in a couple of years as well, but I want to make sure that whatever quality of life I have, I don't spend in the hospital. I don't want to take any medications. I don't want to take any insulin. So that is the main reason. It has to be a behavioral lifestyle change. But anyways, thank you so much for all your time. I know you are a very busy surgeon. At least that's what you wanted me to tell people. But again, my audience, please check out Dr. Praveen Raj. Just Google it. He has written so many articles. He's a president of so many associations. But the only thing I know that he was a president of a cultural club when I was in the college. Just a trivial fact, we had two classes of dancers. Tier 1 dancers is him and his other colleagues, and the Tier 2 dancers is me. But anyway, so good to talk to you again. I'm pretty sure he'll come back on the channel for future updates as well. Again, thank you so much, Ra. Thanks so much for your time.
Thank you, Palani. Wonderful. See you. Bye.